Hello and welcome to this presentation on bladder cancer. My name is Naomi Dry and I'm currently a core surgical trainee in the Northwest. Just to start with, thank you very much to Mr. Coley and the Association of Laparoscopic Surgeons of Great Britain for their collaborative work on this. This presentation will cover the histology, etiology and risk factors. We'll run through the presentation, investigation, then cover some key management and follow-up of bladder cancer. Finally, there'll be some case discussions and questions at the end in a MCQ format. So let's start by covering the histology. As with most cancers, they can be divided into benign and malignant. Benign bladder tumours are normally papillomas. The vast majority of bladder tumours, however, are malignant. These are divided into urothelial, of which the most common is transitional cell, squamous cell carcinomas, and adenocarcinomas. Transitional cell are the most common in developed countries, making up about 90% of diagnoses. However, in developing countries, squamous cell cancers are more common. Most arise from the bladder urothelium, but you do get a minority that arise from the upper tracts. For histological purposes, they are also then further divided into muscle invasive and non-muscle invasive tumours, and this has a huge impact on the treatment path that we follow. Environmental carcinogens are strong triggers for the transformation into neoplasm. These include tobacco and paints and dyes and metals and petroleum products. Genetic abnormalities also underlie the development of bladder cancer. These can include the inactivation of tumour suppressor genes, including TP53, or inactivation of RB1, or then overexpression of oncogenes, which include the ERB2 receptor tyrosine kinase 2, or the endothelial growth factor receptor. Some generic risk factors for the development of bladder cancer include age and sex. So males are 3 times more likely than females to develop bladder cancer. The mean age of diagnosis is roughly 60 years of age. There are slightly different risk factors between transitional cell carcinoma and squamous cell carcinoma. Transitional cell carcinoma is associated with occupational exposure of dyes and any aromatic amines, and significantly associated with tobacco smoking. Squamous cell carcinoma is associated with long-term inflammation of the bladder. This can be related to either a schistosoma hematobiomum or a long-term catheter use and regular urinary tract infections or pelvic irradiation. So how may a patient with an underlying bladder cancer present? By far the most common presenting complaint is hematuria, and it is often painless. It can be macroscopic or microscopic. 85% of patients with bladder cancer will have a macroscopic hematuria. Of those with microscopic hematuria, 5% will have an underlying bladder cancer. Slightly more atypical presentations include urgency, frequency, or dysuria, or patients may experience recurrent UTIs. They can also present with systemic symptoms of metastatic disease that could include bone pain, flank pain, weight loss, or lower limb edema. Let's just consider some differential diagnoses for hematuria before moving on. Nephrolithiasis is one of the most common causes of macroscopic or microscopic hematuria. Urinary tract infections often cause microscopic along with prostatitis. Trauma is often noted in the history, but this is a common cause, say a elderly patient pulling out a catheter. Any patient on anticoagulants is more likely to have hematuria in relation to any of the previously mentioned causes. And finally, interstitial cystitis, again, more commonly will cause a microscopic hematuria and is often persistent. So how do we investigate patients with possible bladder cancer? Well, this is often prompted by hematuria and will involve a triple assessment with a flexible cystoscopy, a CT urogram or ultrasound renal tract, and a urinary cytology. Urinary cytology isn't done everywhere and is only really beneficial for detecting high-grade disease. Any lesion identified with these investigations will then go on to be biopsied, and it will only be after this and if invasive disease has been detected that a patient will have further imaging to look for metastases. That will be in the form of a CT, chest, abdo-pelvis or MRI, and a bone scan depending on their ALP. You'll also do obviously some baseline blood tests, FBCs, LFTs, UECs. This is an example of what you might see on a flexible cystoscopy. You can see a classical papillary-like tumour, which is probably a transitional cell carcinoma. Now, a flexible cystoscopy, you can use white light, which is what you can see in the image, blue light imaging or narrowband imaging. Narrowband imaging is good to look for possible CIS, carcinoma in situ. Here you can see a couple of examples of CT urograms. The one on the left is of the bladder, and you can see an area where the arrow is pointing of a likely bladder tumour. The one on the right is showing the upper tracts and is the delayed phase of a CT urogram. You would see a narrowing and a lack of filling of the ureter, which would indicate a obstruction and narrowing of the ureter. So we've done all these investigations and we've found that our patient has a bladder tumour. We now want to go on and find out the grade and stage, as these are really important in predicting the outcome for this patient. The grade of a bladder cancer is divided into three, low, intermediate and high. This is G1 to 3 respectively. Those that are classified in the high grade will show features of hyperchromatic. They'll be hyperchromatic, they'll have enlarged nuclei which vary in size, and they'll have a high mitotic rate. So bladder cancers use the TNM staging system to classify their staging. Here we'll just discuss the tumour, so the mass itself, and we will use a picture to understand its progression. So CIS is non-invasive bladder cancer. TA is just a cancer of the epithelium, and then T1 invades the lamina propria. When we move to T2, we're then progressing to muscle-invasive bladder cancer, which invades the muscularis propria, and then T3 invades perivesical fascia, and T4 invades local structures. Then we move on to the N and the M, which obviously mean involvement of nodal lymph nodes, and then M is the distant metastases, M0 is none, and M1 is the presence of distant metastases. Okay, so to move on to the management of bladder cancer, as I suggested earlier in the presentation, this varies from muscle invasive and non-muscle invasive cancer. Any non-muscle invasive cancer is likely to not initially be discussed at an MDT if it is simple and low grade, but any other cancer will be discussed at the MDT for decisions about further management. Okay, so the management for non-invasive bladder cancer, which is stage TA, T1 and TIS, so carcinoma in situ. So these patients will have had a lesion identified on flexible cystoscopy. They'll have gone for a TURBT, a transurethral resection of a bladder tumour, of which they must obtain a detrusor muscle, or they need to go back for a repeat TURBT at 6 weeks. They'll then get a single dose of mitomycin C at the time of the operation. Now, low risk don't need any further intervention, just follow up. Intermediate risk need to be offered 6 doses of intravesical mitomycin C. High risk need to go on for a repeat TURBT as soon as possible, and definitely within 6 weeks. And they are offered a radical cystectomy, versus intravesical BCG, which is induction and then a maintenance dose. So you're probably asking what makes it intermediate risk, what makes it high risk. Well, this is by the grading of the cancer and by the stage, so the TA, the T1 or the TIS, and the presence of carcinoma in situ. So generally they're divided into low, intermediate and high risk. So low risk are solitary tumours, TA and low grade. Intermediate are basically what doesn't go into either high or low, and then you've got high risk, which are any tumours that are T1 and then G3 or G2 generally as well, and anything with CIS in presence or large or recurrent tumours. Follow-up of non-muscle invasive bladder cancers is in the form of regular flexible cystoscopies. For low risk, they have a flexible at 3 months and then a repeat at 12 and can then be discharged. Intermediate, they have a flexi at 3, 9, 18 months and then yearly, possibly discharged at 5 years. High risk will have a 3 month, 2 yearly, 3 months for 2 years, 6 months for 2 years, and then annually thereafter. If they have had a cystectomy or BCG for the high risk, they'll have, so if they've had a cystectomy, they'll have CT scans to look for upper tract pathology or hydronephrosis and for the development of metastatic disease. So muscle invasive bladder cancer, which is T2 and upwards, is treated much more radically, so with radical cystectomy or radiotherapy, plus or minus neoadjuvant chemotherapy for those that are suitable for it. Adjuvant chemotherapy may be given to those that didn't have neoadjuvant, say if they've been upgraded in their grading system. They will then be followed up with the same as high grade or high risk non-muscle invasive, so with regular CT scanning or with regular and long-term flexible cystoscopies. So there are certain risk factors that can predict the recurrence of or progression of bladder cancer. The most important is the grade and stage of the bladder cancer. Lymphovascular invasion has been shown to increase the risk of progression. The presence of CIS increases the risk. Smoking and histological variance is also key in predicting outcomes. So 75 to 80% of bladder cancers are non-muscle invasive. Now, non-muscle invasive have a very good 5-year survival, which is about greater than 85%. They do have a high recurrence rate. The use of risk calculators, including the EORTC risk calculator, does help to predict the chances of recurrence. This looks at factors including the number of tumours, the size of the tumour, any prior recurrence, stage of the disease, and any presence of carcinoma in situ and the initial grade of the tumour. Muscle invasive bladder cancer has a 5-year survival rate of approximately 77%. Metastatic urothelial carcinoma has a pretty poor prognosis with an estimated 5-year recurrence-free survival of about 4% to 35%. And that brings us to the end of the presentation. Please follow this QR code to get some extra bonus questions. Thank you very much. Goodbye.